So we can put the ICERs together and trace out the cost effectiveness frontier. And the point of the cost effectiveness frontier is that it's a subset of the treatment strategies available where you're removing all of the ones that are wholly dominated to just compare between the ones that are potentially cost effective. So consider this kind of like a plot of all of the possible treatments for a disease called batitis. And we have hundreds, like thousands of dollars on the x-axis and years of life on the y-axis. So if something is very expensive, it'll be far to the right. But if it's not very effective, it won't be very high up and down on the y-axis. So B, for example, and even F will be dominated. So we can trace out along the outside the cost effectiveness frontier, stretching from A to C to H. Now, I is a little bit shorter than H on the y-axis, so it's fewer life years, but it's further to the right in dollars, so it's more expensive. So it's wholly dominated. That's why H is included and not I. So when we're talking about cost effectiveness, we have to measure costs as well as effectiveness, right? And it's actually not as straightforward to measure costs as one might think. Whether or not the treatment is going to be cost effective depends on the perspective that you're taking, whether it's the government administrator, because then all costs kind of count. But then from the patient's perspective, it would really only be the costs that are directly borne by them. So let's say there's a new lung cancer treatment and it's $1,000. But, let's say it has to be administered in a distant location and it takes a long period of time. So that could be very expensive for a person to consume. The treatment could be uncomfortable or unwanted side effects, or perhaps have unwanted side effects like later in life. So it's actually unsettled exactly which costs count. And so it's important to read an analysis kind of in full to understand when somebody is doing a cost effectiveness analysis, what they're considering and what perspective they're taking. Whether or not future costs should be included is, again, an ongoing area of debate. Let's say the lung cancer patient is cured, but then they're going to go on to have a costly heart attack. Is the cost of that included in the cost of the treatment, for example? Measuring effectiveness is actually a bit less straightforward. So effectiveness is kind of difficult to measure in healthcare. A lot of times we'll talk about increased life expectancy, especially, let's say, for cancer treatments. We'll say it increases the like the probability of 5-year survival or something, but some of them affect quality of life. Like some treatments affect quality of life, let's say mobility or freedom from pain. And so in that case, a lot of times what we'll look at is quality adjusted life years. This is a pretty common practice, QALYs. This approach combines quality of life and life expectancy into a single index. So in the QALY calculation, every year of life gets a quality weight between 0 and 1 that reflects the quality of that life year. So if you're living in perfect health, then the quality weight would be 1. It'd be a full QALY. But perhaps a year, let's say with a chronic cough and insomnia, is 50% of a QALY, or confined to a wheelchair is 25%. So, who has the right to make this judgment is a good question. And there are a lot of different ways that people have addressed that question, and we'll come back to discuss it. But, so calculating the QALY requires 3 pieces of information: the probability of surviving, the quality of life, and also a time discount rate to know how much 10 years into the future should be weighted versus today. Another thing you can do instead of a QALY would be the quality adjusted life expectancy. It's the number of additional years you're expected to live, weighted by the discounted quality of life. It's just like the expected value of QALYs, essentially. So it's the sum of the discounted QALYs times the probability of life. So how do we elicit these quality weights, whether we're doing the expected value of QALYs or the number of QALYs? How do we develop those quality weights? There are 3 different ways we're going to talk about. One of them is just a visual analog scale. They just ask people, just through surveys, to rate these health outcomes between 0 and 100, where 100 you're really It's like the best possible health that you could think of. And it's really simple to administer, and that's why people like to use it. But it's kind of hard for people to think about. If we give you three health states where, one is better than the other, a lot of times people will just put them as 25, 50, 75, even if two of them are a lot worse than the other one. So they don't necessarily stretch them out very well. And then another one is the standard gamble, where you can choose between having H with certainty, a particular health condition, let's say, hypertension, or you can take a gamble where you have some probability of full health and some probability of death. And so the point of indifference, the point at which you're just kind of like, I don't know, it's not, neither of those is like particularly better than the other. Is kind of like what they would consider to be the quality weight of that condition H. So it's essentially like, how much better is having this condition than like the probability of dying? That one is a little bit better at getting at people's, like how much strongly they feel about one versus the other. But people are also very risk averse, as we've talked about. And so they're not that good at kind of like putting cold hard numbers on these probabilities in surveys. So finally, we have the time trade-off, where people have to choose between living for some number of years, T, with this health state before dying, versus living a shorter period of time, tau, in perfectly full health before dying. And like how many fewer years would you be willing to take in perfect health versus more years with this disease? And then the quality weight is like the ratio of the two periods of time. And again, this one does reflect your intensity of preferences better than that visual analog scale, how much stronger you feel about one thing than another. But it can be biased if tau, the shorter amount of time that you're willing to have, is a function of age. So, when you're older, you might be kind of more willing to have poorer health than when you're younger. So it's not exactly a true elicitation of like that condition. It's kind of biased by an individual's characteristics, specifically their age. And so whose opinion is correct in quality surveys? People who are healthy who don't have a particular disease might be ill-equipped to imagine what that would be like. Expert panels are actually not very good at representing their patients' preferences. They don't necessarily know. And people who have lived with a particular condition for decades tend to understate the amount of suffering that it would be for a healthy person to suddenly take on their state. For example, a person who has lived with blindness for a long time has developed a lot of skills, and that's life for them. Versus a healthy person who were to move into that state might suffer a little bit more than would be anticipated by the blind person. So, whose response is more accurate? The healthy person, the person who already has the condition, or an expert panel? It's really hard to say. So a lot of times people just kind of use a combination of these different measurement techniques.